Good morning, everyone. Today, the clinically presented by Abhijit Jain, and it will be moderated by Professor Sitaram and Professor Madhusudhan, and Professor Azhar Perweiz just joined. So it's all yours, Sitaram and Madhu and Arvish. Pervez, you can take over now.
Good morning, sir.
Azhar, your mic is muted.
Yeah. So good morning.
Jain, you can share your screen.
Yes, sir. Good morning, everyone. Patient, 67 years old male, resident of Chhattisgarh, retired police officer by professor, came with chief complaints of pain in the pain in the upper abdomen for the past 3 months, loss of appetite and weight for the past 3 months. Patient was apparently all right when he noticed pain in epigastrium in the right upper quadrant, non-radiating, not related to food, and without any aggravating or relieving factors. He also complains of early satiety and unintentional loss of weight, about 4 to 5 kgs in the past 3 months. So no history of nausea, vomiting, no history of altered bowel habits, no history of GI bleed, no history of jaundice, no history of abdominal distension, no history of any abdominal trauma, no history of any chronic drug intake, no history of fever, no history of similar complaints in the past, no history of mass or swelling elsewhere. Apart from these negative histories, sir, I would like to know if the patient had any history of dysphagia to rule out any GE junction or esophageal tumor, history of altered sensorium, history of reduced urine output to rule out decompensated liver disease, history of bleeding for gums or any spontaneous bleed, and a history of backache, seizures, back pain, seizures, or shortness of breath for metastasis. Past history, he was diagnosed HbS-Ag positive in 1998 after a voluntary blood donation, and he had not sought any further investigation or treatment for the same. Known hypertensive for the past 2 years and on regular treatment. No history of any other comorbidities, no previous surgeries. Personal history, patient has no addictions, takes mixed diet, sleep normal, appetite reduced, normal bowel and bladder habits. Family history is not significant. So to summarize, my patient is a 67 years old male with pain in epigastrium and right upper quadrant, with early satiety and loss of appetite and significant weight loss. He is also hepatitis B positive. So my differential diagnosis, as he is a old male with dull aching pain and significant weight loss with early satiety, my differential diagnosis would be malignancy of liver or stomach.
Okay, Abhijit.
Yes.
Dr. Azhar here. So your differential diagnosis, you want to broaden your differential diagnosis, like you first put liver malignancy. So patient has epigastric pain and weight loss, which is substantial, and unintentional, you said 4 to 5 kgs in 3 months.
Yes.
So do you want to put anything before liver? And something which you missed during, if you are thinking of stomach cancer, there are certain things that you should elaborate in history. So first is, do you want to put anything above liver? Any other malignancy? I agree. I think the chair also agreed that maybe it is malignancy only. Like if there is a epigastric pain, to my mind, with weight loss, first pancreatic cancer or gallbladder cancer may come before liver cancer. And for stomach cancer, your symptoms like non-specific prodromes, not feeling well, not feeling appetite, or non-specific systemic symptoms, which is most common in stomach cancer before actually an dysphagia or something happens. Should have been elaborated. And why you think it is malignancy only, not any benign condition? Because it started with pain. And if somebody is having pain for 3 months not eating, then he might lose some weight.
So the weight loss is significant, and is also hepatitis B positive. So that puts liver at the risk of various field effects. So
Yeah, so one thing I agree that because of hepatitis B positive, you are going toward liver, that I agree. Good, that this is a good point. But weight loss, is it 3-4 kg to 5 kg in 3 months quite significant?
greater than 10% is significant, sir.
Okay. Dr. Sitaram is here, sir. Please move.
So how you differentiate pancreatic cancer?
Sir, pancreatic cancer, the pain is actually sir, dull aching and non-radiating. Body of pancreatic cancer might present as pain with radiating to back. Other thing is, sir, head of pancreas malignancy might present with jaundice also, sir. But as the patient gives no history of jaundice,
If it is body, was
body,
it the epigastric
yes,
area?
sir. Yes, sir. Epigastric pain with uh, radiating to back. Yes, sir. I would like to put pancreatic body cancer as a differential diagnosis.
Since you have put stomach cancer as one of your differentials,
Yes,
I think you should, in the history, you should talk about symptoms related to chronic blood loss, anemia.
yes, sir. It has been given, sir, that patient has no history of GI bleed, sir. And no
Yes,
history of
may not have GI bleed, but hemoglobin may progressively come
Yes,
down because
yes,
of undetected blood loss.
yes, sir.
That is something that you should have brought out. You said shortness of breath as a symptom of secondaries, but shortness of breath could also mean anemia.
Yes, sir.
Okay.
Yes.
Can we move on?
Yeah, please.
General physical examination. Patient is conscious, cooperative, and well-oriented, moderately built and nourished. BMI is 22, height 1.64 meters, and weight 60 kgs. ECOG 0, breath holding time 43 seconds. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. No palpable supraclavicular lymph nodes. No signs of dehydration. No signs of liver failure. Pulse is 78 beats per minute, BP 130 by 70 millimeter of Hg. Respiratory rate 18 per minute. Patient is afebrile, skin and spine is normal.
Okay, Abhijit, what is ECOG?
Sir, ECOG is mainly used to judge the performance status of the patient, sir.
What is ECOG?
Expand, ECOG.
Yeah. You know what is ECOG stands for, and of course, you know that it is for performance status. It is the Eastern Cooperative Oncology Group, which has given this classification to classify your patients into performance status, which bedside is a good marker to choose a patient for intervention. So what are the different ECOG grades?
So ECOG 0 is when the patient is able to do all his previous his
So
all.
my question's answer would be just go and read it well before you appear for your final exam, because all of you people write ECOG. Please do read about it. Okay. And second, you said that no signs of liver failure. Would you like to elaborate what are the clinical signs of liver failure clinically you see in your patients?
Yes, sir. Liver failure, sir. Patient might present as icterus, loss of pubic and chest hair,
Okay, okay.
ascites, testicular atrophy, loss of muscles of malar eminence and dupuytren's contracture, muscle atrophy, sir, And
Why these people have testicular atrophy?
that liver is actually the testosterone level decreases in patients with liver failure, sir. That also leads to gynecomastia.
Why testosterone level will decrease in liver failure? Okay, move on, please.
On inspection, the abdomen is flat, umbilicus is central and inverted. All quadrants move correspondingly with respiration. No visible scars, sinuses, engorged veins, pulsations or peristalsis. Hernial orifices, no visible cuff impulse, no renal angle tenderness. Abdomen is soft, non-tender on palpation. Spleen and liver are not palpable. A firm lump of 4 cross 3 centimeter is palpable in epigastrium, which is non-tender with smooth surface, moving with respiration. Lower border palpable about 3 centimeter below xiphisternum and extending below costal margin superiorly. Hernial sites, no palpable cuff impulse. On percussion, upper border of liver dullness is at 5th intercostal space. Dullness over the lump is continuous with that of liver. Liver span is 14 centimeter in mid-clavicular line. Flanks are tympanic. No bowel, normal bowel sounds heard. On
You say
digital
flanks are tympanic. Sorry, Abhijit, I'm interrupting you. You are saying flanks are tympanic. What do you want to say here?
sir, in ascites or minimal ascites, flanks would be dull, sir, because
So
of
yeah, basically here it is better as when you are presenting it.
Yes.
Flanks and tympanic suggestive of lactin, there is no ascites or free fluid. It helps. Okay, some leading answers is better than just. Okay, move on.
On digital rectal examination, perianal skin is normal, no palpable mass, gloves stained with normal colored faces. CVS, both the heart sounds are normally heard, no murmurs. Respiratory system, aeratory, bilateral equal, normal vesicular breath sounds, no crepitations or added sounds. CNS, no neurological deficit. My patient, 67 years old male, HbS-Ag positive, not on any medications, known hypertensive on regular treatment, no addiction, performance status 0, presence with complaint of pain in the right upper abdomen, with loss of appetite and weight since last 3 months. On examination, patient is moderately built with BMI 22 kg per meter square with firm palpable lump in the epigastrium of nearly 4 cross 3 centimeter. Dull on percussion, continuous with that of liver, with no signs of liver failure. My most probable diagnosis in this patient is malignant space occupying lesion of the liver, query hepatocellular carcinoma or metastasis.
Could this be some liver abscess?
Sir, short history of pain, no fever with significant weight loss and satiety and HbS-Ag positive, sir. And the lump is actually palpable and firm with non-tender, sir. So I would like to put malignancy as my first diagnosis.
Even though metastasis is more common than primary cancer,
Yes, sir.
put primary cancer first. Why is that?
Sir, negative history, sir. No history of other no GI, no other GI symptoms, sir. And he's also HbS-Ag positive, which
That is
puts him at
HCC positive status. So what will you do for this patient?
first I would like to evaluate him with basic blood investigations, complete hemogram, for looking for to look for pancytopenia, anemia, in view of possible portal hypertension. I would like to get his LF liver function test to calculate his child pug score. Renal function test because I would like to do some contrast imaging down the line, and also to rule out hepatorenal syndrome. Serum electrolytes because sodium would help in calculating his MELD score. INR to calculate the MELD score and also see if he is having any coagulopathy. I would like to send his viral markers also, sir, to see if he is HBS, to confirm the HBsAg status, sir.
Let's start one by one. Huh? Complete blood picture you want?
Yes, sir.
Huh.
Sir, there is no pancytopenia, sir, in this case.
So clinically also you doesn't have any
Yes, sir.
corporal spleen, no ascites, no stigmata of chronic liver disease.
Yes,
Huh?
sir. Yes.
Still you expect pancytopenia?
I would like to confirm it, sir, with blood investigation, because portal hypertension in these patients cannot be ruled out on physical examination. Patient will be normal by physical examination, but still he can have underlying portal hypertension.
How much percentage of the people without splenomegaly will have a portal hypertension? Yes, you are right, but how much percentage, you know? Okay, next.
Blood urea 26 milligram per deciliter and creat 0.82 milligram per deciliter, which is normal, sir.
Hmm.
Is total bili 0.6, direct 0.2. OTPT is marginally raised, 68 units per liter and 82 units per liter. SAP also 160 marginally deranged. Albumin is fine, sir, 3.7 gram per deciliter. INR 1.04, sir, it's normal.
So do you think that is it giving some clue? Wait, LFT.
Yes, sir. Underlying hepatitis is there's a chronic hepatitis
Yeah.
pointing out to that, but all in all, sir, he is a child A only, sir.
Elevated OTPT.
Yes, sir.
Hmm.
Underlying some inflammation is there's chronic hepatitis is there due to HBsAg positive.
So what do you want to do for that?
Sir, I would like to get his HPV viral DNA quantification test, sir. And if it is greater than 10,000 copies, I would like to start him on some nucleoside analogs, sir, like entecavir.
Anytime liver malignant lesion with
Sir,
this type of OTPT elevation possible?
Sir, liver malignancy, actually, it is seen that ongoing active replication of hepatitis B virus enhances the chance of recurrence, sir, post-resection.
No, I am not saying
Yes.
if there's forget about hepatitis B status, that too I agree. Only per se malignancy will cause us this type of picture anytime, especially liver HCC.
Yes, a malignancy can cause raised.
When
It can cause raised liver enzymes when malignancy can cause.
if any HCC involving the portal vein, thrombus, HCC thrombus, can it be possible?
Yes.
Okay, next.
HBsAg positive, sir. Next, actually, I would also like to send his serum AFP, sir. Yes, sir.
Only serum AFP or something else? Or other markers also?
Other markers of malignancy, if we are suspecting some colonic secondaries, then we can send serum CEA, sir.
No, see, if somebody is hepatitis B positive and a liver mass, you just cannot just stick on that one diagnosis of HCC. Like Dr. Sitaram say, that still the liver as well, most commonly are the secondaries.
Yes, sir.
So when you're sending tumor markers, I think, in my opinion, you should also send CEA at least. Although there are probability of high toward HCC is going because of HBs positive, but does not exclude presence of liver metastasis or secondaries. Any other tumor markers simultaneously if you're sending blood sample you want to send?
CA 19.9.
So other hepatobiliary malignancies as a secondary, you want to take it as a possibility as a secondaries to the liver, right? Oh.
Is normal, sir, 3.6. CA 19.9 is also normal, 15.6.
What is the normal CA 19-9?
Sir, it's around 27 to 35 is the normal value, sir.
And what are the units? International unit per ml. What is that alpha fetoprotein units are?
Nanogram per ml. Sir.
Right.
Can it still possible AFP normal with HCC, your primary diagnosis?
Yes, sir. Around 30% of patients with HCC can present with normal AFP, sir.
So
Or if
what,
the tumor is small in size, sir.
when AFP is normal, what other marker you will send? If you are clinically and radiologically strongly suspecting, still you can send another tumor marker. What is that?
S-carboxyl prothrombin, sir.
Yeah, PIVCA2.
PIVCA2. So you said 30% AFP is negative in HCC. So what are the HCCs where the FP is negative? Although 30% is, I think, too much. Dr. Madhu will be better knowing this. I'm not very regular in this. 30% is too much. I think 10 to 20%, but still is okay. So what are the HCC where AFP is normal? What are the type of HCCs where
Intrahepatic cholangiocarcinoma or
this is not
other types
HCC,
of
no?
Yeah.
Intrahepatic cholangiocarcinoma is HCC.
or other types like sarcomatous HCC, sir, or fibrolamellar carcinoma. That HCC is not.
It is sarcomatous or something else. Anaplastic poorly differentiated ones can have normal AFP. Okay. So why PIVCA2 is high in those patients where AFP is normal? Maybe AFP is normal, PIVCA2 is high. What does PIVCA2 is how it signifies the diagnosis, PIVCA2?
Sir, it is actually a protein that is induced by deficiency of vitamin K, sir.
So how many percentage FP is normal and PIVCA2 is positive? Okay, move on. So what is your diagnosis with these all? AFP is normal, HBs positive, liver as well, non-tender.
AFP is normal, sir. I would still place hepatocellular carcinoma.
You have not done CEA.
Yes, sir. Yes, sir.
You have done CA 19-9. You have not done CA so far. You know the diagnosis maybe, but we have not reached to that point. So still you are going to HCC. You are not still doing CA, right?
EA can be done, sir, to rule out secondary, sir. Or
So when this situation like this arises where all the tumor markers are negative, you have not done any imaging, some liver mass is there. So you certainly would like to do CA before going forward. So most probably, let's see. Okay, move on. Have you done CA?
Not done, sir.
Okay, no problem. Move on.
It is not available.
No issues. Okay. So I think Dr. Sitaram and Dr. Madhu, we should do CA. If these two tests are normal, we are not reaching anywhere right now. What do you think, sir?
Yeah.
I think because the HPSAG status is positive, CA takes, as you said in the clinical examination also, is fixed on primary cancer and not secondary
Right.
cancer. So, would you do an ultrasound scan, Abhijit?
Yes, sir. I would like to do a basic ultrasound scan, sir, to see if any other primaries can be found, and also to see the status of the liver, sir, like how size of the liver, the echo texture of the liver, whether any nodularity is there. Size,
Do you have the ultrasound? Show it. Yeah.
liver is normal in size and shows
Yeah, we can read. We can read. Give us your interpretation. What are the good things for the patient? What are the bad things for the patient?
Sir, liver is not shrunken, sir, and there is no ascites, and portal vein is normal, sir. So, but there are multiple lesions, sir, in the liver, as opposed to the clinical examination in which we had suspected a single lesion, sir. And there is internal vascularity also uh, in the isoechoic lesion, so that mostly points to malignancy, sir, with the area of necrosis that mostly points to malignancy. But well-defined small lesions in the contralateral lobe that might suggest metastatic HCC or secondaries from other primaries, sir. So there are multiple, so there may be secondaries also, sir.
Okay. So what next?
I would like to evaluate with a triple phase contrast CT, sir, to see how big are the lesions, and to see the vascularity, and also to rule out any other primaries which might have caused secondaries in the.
CT or MRI?
I would first like to go with CCT, sir, because as the lesions are multiple, the we have to also look for other primaries, sir. It might be a
You want to
second
do a CCT or triple phase CT?
triple phase CT, sir.
So is it difference between CECT and triple phase CT?
Triple, yes, sir. I would like to go ahead with a triple phase CT, sir, because triple phase CT enables us to look at the different phases of enhancement, and it actually helps us to differentiate between a primary HCC or secondaries or atypical HCCs.
So how is triple phase CT is performed, and how this is different from a CECT?
Sorry, sir.
How a triple phase CT is performed, and how it is different from a contrast enhanced CT?
Sir, triple phase CT is performed by giving 100 to 120 cc of non-ionic contrast at 3 to 5 ml per second, sir. And first, a plain CT without contrast is taken, sir. Then, at different points of time, like from at 18 to 30 seconds, an arterial phase is taken, sir. Then at the 60 to 70 second portovenous phase, followed by an equilibrium phase at 3 to 4 minutes is taken, sir. So normally, the hepatocellular carcinoma, it gets its blood supply from the hepatic artery, sir, as opposed to the normal hepatic parenchyma, which gets its blood supply mainly from portal veins, sir. So on a late arterial phase, the hepatocellular carcinoma, it lights up more, like it is more enhancing than the rest of the hepatic parenchyma, as opposed to in the portal venous phase where there is washout in the tumor, and the normal liver parenchyma enhances.
Okay, shows this.
I think CT images are available for you, so you can take control and show us.
Yes.
talk about this.
So plain CT, it shows hypodense lesion in the second and third segment of the left lobe of the liver, sir.
Hmm.
No other lesions in the right lobe could be elicited on the plain CT, sir.
So can I
And-
just stop a little, go up, please? Go
Yeah.
up a little, please. So you see something inside this liver as well. Some,
Air pockets are there, sir.
yeah. What are those?
So
And why
might
are
be due to necrosis, sir. Necrosis and secondary.
anything other possibility? Any other possibility apart from necrosis? Maybe tissue diagnosis have obtained somewhere before the scan. Maybe the air is introduced because of that. Maybe.
Just go above that. That central area is hyperdense.
Yeah.
A little bit up. No.
Yeah.
Up, sir.
Yeah. Yeah. So just central area more hyperdense. What was the reason?
Why the central area is more happening? As Dr. Sandhu said.
Not one. Just go down little bit.
Yeah, a little bit of budding is there. Yeah. Okay.
What do you want?
Fit all three phases and tell us
Yes.
what you find. Give us your diagnosis.
Yes.
What findings and what your diagnosis.
Yes.
Abhi, simultaneously keep on explaining what you are seeing.
Sir, in the arterial phase, sir, we saw, as expected, the normal liver parenchyma is not enhanced, sir.
Normal
But
is the liver parenchyma according to you is normal?
sir, some nodularity is there, sir. Some
Mhm.
and some that liver surface is not smooth, sir. Some not.
Yes. And what about the caudate? It's hypertrophied.
Yes, sir.
Not much, but yes, it is hypertrophied.
Mm.
Contour is not maintained. Okay, go on.
Sir, there is peripheral enhancement in the left lobe lesion, sir. And also there is a cystic lesion, sir, in the right lobe of liver.
You have a triple phase. You have to tell us which segment.
Can't say cystic.
Segment 6, sir.
How you know it's segment 6?
Sir, it's seen below the junction of hepatic vein, sir, and it's in the lateral part of the liver.
Cannot say in arterial phase, better go by portal.
yeah.
phase. Yeah.
The portal venous phase, you have to say that.
Yes.
Means the venous phase, you have to see the right vein and see which is in the medial segment or lateral segment. And once you're in the medial lateral segment, then you see the portal venous branches. Accordingly, you decide it is 7 or 6, 8 or 5. Okay.
In the portal phase also,
In the arterial phase, you go to describe the scan. In the arterial phase, go to the lesion. Yeah, go to the lesion. Yeah, it goes slow, Peripherally, you see some vessels which is running.
there's
Okay.
yes, sir,
Yeah,
internal vascularity is there, sir.
Yeah, see this is peripheral vessels like this,
Yes,
right? Peripheral vascularity,
yes. There's some central necrosis is also there, sir. It is not
Right.
enhancing.
So this is how you describe this lesion in arterial phase.
Sir, it is enhancing peripherally, it is enhancing in the arterial phase, sir, with non-enhancing areas with air pockets in the center of the lesion, suggestive of neoplastic lesion with necrosis, sir.
So one more thing is when you are seeing peripheral vessels like these arterial vessels on the periphery of a lesion in the liver with some nodularity with hepatitis B positive. This is almost certain signs toward HCC, some sort of bulge.
Yeah.
Okay, Dr. Sitaram is there. Dr. Madhu, please, please. Anything to add, please?
So you see other lesions also in the liver, isn't it?
Yes, sir. Right side segment 6, there is one more lesion.
I think portal venous phase will show you better.
Yes.
So,
Yeah.
yeah.
Yes.
So where is that?
Segment 6, sir.
That is
Yeah.
6. Okay.
Yeah.
This is non-enhancing even in the portal phase, sir.
Okay.
Some internal septations can be there.
Is it cystic or it is a solid?
Sir, it is some internal septations I can see, sir. So it is a complex cyst only, sir. Cannot be 100% sure of the cystic nature of the. Some internal fine septations are also there.
Any other lesion?
Here also some
Yes.
one abutting small lesion is there, sir. Just in segment 6 one.
Okay. Any other lesion?
Is that tiny going along the right posterior portal branch?
Yes.
Okay, your marker. Yeah. Okay. Go on.
So whatever I can see from this picture, that segment 6 lesion doesn't look like cystic to me. And so what is your diagnosis, Abhijit, based on these CT films?
Sir, on CT, there are no any other apparent primary that is seen, sir. Colon and small bowel pancreas is normal, sir. And we can see a lesion that is enhancing in the arterial phase, sir. And there is a small enhancement is also there in the portovenous phase also, sir, in that lesion. So, and there is one more complex cystic lesion in segment 6, sir. So, my opinion, sir, it might be an atypical HCC, sir, with metastasis to contralateral lobe, sir.
You call as a
Is it same as-
metastasis?
Yeah, please.
But I
Inability
would
to
like to
see
further investigate those small lesions, sir, with An MRI if it is.
It can be a synchronous lesions, no? Chronic hepatitis
Multifocal
B
HCC.
background. Huh?
Yes,
That
sir.
is commonest than having a metastasis to other lobe. Huh?
Yes, sir.
Can this be a multifocal HCC, as Dr. Madhusudhan is possibly pointing? Abhijit?
Yes, sir. Multifocal HCC is because it is a field effect, sir.
So what, yeah, one lesion is enhancing, other is you're not sure whether enhancing or not. There's HCC evolves. All these parameters of radiological importance develops with over the period of time.
Yes, sir.
So in some of the smaller lesion, you might not get all the details which you're getting into the segment 3 lesion, right?
Yes.
There is a possibility of multifocal HCC. How intrahepatic cholangios will be different from these?
Intrahepatic cholangiocarcinomas, actually, there are more of desmoplastic in region, sir, mass forming type. So the contrast is retained in the equilibrium or delayed phases, sir.
So non-enhancement is the arterial phase, right? In
Yes.
arterial phase, there is not enhancement. And what else you can have? Other surrogate markers of intrahepatic cholangio.
Sir, they can be IHBRD, sir, if it is infiltrating into the
intrahepatic
ducts, of small ducts of the.
What will be the capsule of the liver in case of
Uh,
intrahepatic cholangiocarcinoma?
there will be capsular retraction, sir, because of desmoplasia in intrahepatic cholangio.
And usually the liver is normal, like unlike in this patient, which is nodular.
Yes.
So it is a nodular liver with multiple liver SOL. Segment 3 is typical of look like HCC. Okay. Okay.
So
Next,
you
what
want,
next? Yeah.
you want MRI?
To evaluate the other lesions, sir.
Yes, yes. I think MRI is available to us.
So Abhijit, the only question is, do you routinely need to do an MRI or you do MRI in specific situation? Like you have both the investigation, CT triple phase, which you said that I would like to start with triple phase CT. And you always do an MRI subsequent to CT triple phase or you selectively use? And if
No,
selective,
sir.
what are the
We
conditions?
selectively do, sir. If we are suspecting a cholangiocarcinoma and we need to look at the bile duct anatomy, sir, to plan our resection.
No, in HCC. In HCC
HCC, sir,
only.
if there are other multiple lesions which are looking doubtful in CT, then MRI can differentiate better from CT because of greater soft tissue calibration and
Yeah.
differentiation.
No,
As
no.
per the general guideline, if the dynamic CT is not providing all the information and there is diagnostic doubt, second investigation is a dynamic MR, right?
Yeah. What BCLC says, what? When you are three investigations, right? One contrast imaging, CT or MRI, and alpha fetoprotein. If these are not consistent with HCC or doubtful, you have to do triple phase, another dynamic image like contrast MRI. That is a BCLC recommendation.
You understand, Abhijit? BCLC?
Yes. Barcelona Clinic for
Yeah.
liver cancer.
Okay.
Plus in this AFP is normal and your CT is not classical enhancing an arterial phase. Still possible atypical HCC, but it is not classical consistency of two investigations. That is why you need to do contrast MRI or triple phase MRI.
Yeah, let's move on. Show us the MRI. So the segment 6 lesion is what?
Sir, it is uh, mostly filled with fluid, sir, because it is completely enhancing on completely hyper intense on T2 phase, sir. So it mostly points towards a cystic lesion, sir.
Okay, so let's say it's a cyst.
Hmm.
Any other lesion you're worried about?
The primary lesion in segment 2, sir, that is Both hypo and hyperintense. It is there, sir, within the lesion. So that definitely looks like a malignancy, sir.
Okay. So what next?
Uh, Sir, I would uh, like to plan. This is more looking like cystic lesion, sir. So I would like to plan for a formal hepatectomy for this patient, sir.
You have really upset me, Abhijit.
We have to first see the FLR, sir.
You're upsetting me some more. You haven't done anything to see if there are metastases. Have you done a chest X-ray?
Yes. But like to evaluate for metastasis, sir. With contrast CT shows that
It's not chest and abdomen. It's only lower part of chest.
I would like to evaluate him for metastatic disease, sir, if he has progressed or not.
Okay.
For that, I would like to do a chest X-ray or if any lesion seen, then I would like to plan a CT chest, sir.
Okay.
And then patient does not have any bone pain, sir, but like to do a bone scan, sir, for him.
So you have a triple phase and a triple dynamic MRI suggestive of HCC, and you're wanting to do a metastatic workup largely because you want to contemplate some major surgery. So in that situation, you want to go to X-ray chest is a routine investigation. I agree. Then you want to do a CT scan of chest, and then subsequently a bone scan. Do you think there is a role of functional scan like PET scan at this situation? If you're contemplating surgical resection, major surgical resection?
Most of the hepatocellular carcinomas are not FDG avid, sir. They are well differentiated. So PET scan.
Before contemplating major hepatic resection, you don't want to do a PET scan.
Yeah. What are the conditions in established HCC where I do agree majority of the HCC are not PET-avid, but NCCN says only some conditions, some markers will give that which needs PET-CT in suspected HCC. Which are the conditions? That indicates biologically aggressive tumors. Patients with high AFB, will you do?
Yes, sir. Greater than
Patients with bulky lymph nodal disease, will you do?
yes, sir. Lymph nodal disease points to the poor prognosis and higher risk of recurrence, sir.
Patients with vascular invasion of the tumors.
Okay.
And
So you want to look at the this report? Abhijit,
Sorry, yes, sir.
shall we look at the radiologist reports on
Yes,
these
sir.
scans?
Yes, sir.
They are wiser than us, maybe.
Yes. Having the control, sir.
Can you show us CT and MRI reports, please?
Yes. Sir. I'm not able to see the panels of the CT and MRI on my screen. Sorry. Sir.
I think his screen got hung. I think he's setting it right.
Okay.
We can proceed the discussion. Once it's done, then probably we can
Yeah.
again show the reports.
So Abhijit, just tell us what is the current role of PET CT scan in this kind of situation in HCC? What is the role of PET CT scan in HCC? Where does it stand?
Sir, on a CT and MRI, sir, if we are confident that the only one lesion is malignant and the other lesions are benign or innocent, then PET CT is not indicated, sir.
So what is the purpose of PET CT scan in HCC? See, PET CT is not meant for making the diagnosis. It is to exclude the metastatic disease. And then broadly, for the last 20 years, all the literature is suggesting that it can change the management in 20%. You possibly has to select some subgroup of patients for routine PET CT. I'm not saying routinely you do, but some selected group you have to choose. But before contemplating major hepatic dissection, metastatic exclusion need to be done. If you do not exclude metastasis, there is no excuse of finding a lesion subsequent after surgery. Whether it is liver transplantation or whether it is major hepatic dissection, I want to know the opinion about Dr. Madhusudhan and Dr. Sitaram here about the role of PET CT scan in this context, sir. Hello.
Yeah.
Sir.
I wouldn't do a PET CT in this patient. AFP is low. The lesion seems confined to the liver. I can't see any nodal disease. I would do a chest CT, chest X-ray first, chest CT, and then proceed.
Yeah, we also do same way. So basically, when high AF is normal, not having any lymph nodal disease, generally NCCN or International Study Group on Liver Disease both suggest such situation. Standard of investigation is CT chest and abdomen is enough. Only peculiar condition, they said the three conditions which I mentioned, like high AFP, bulky hepatoduodenal lymph nodal stage, or vascular invasion like portal vein thrombus or IVC or hepatic vein thrombus. Such situation, the PET CT is recommended. So we in our institution also we follow like that only.
Yeah, the report is there.
So Abhijit, the report is here.
Yes.
So you've seen the CT report. You can look at the MRI report also. What's your plan? After excluding metastatic disease, what is your plan?
Right.
Abhijit?
Sir,
Yes.
sir, multiple lesions are there, sir. With in MRI, it is showing one lesion demonstrating hyper and heterogeneous enhancement also in segment 7. So this looks to me as a multifocal HCC, sir.
Why not
How
it
are
is
you going to resolve
hemangioma?
this?
But sir, in a CT also the portal washout is not there, sir. It is enhancing both in portal and delayed phases, sir. So it might be an atypical HCC.
What is the classical description of hemangioma of the liver? Can you tell me?
There's a centripetal, this peripheral nodular enhancement is there, sir.
That is there here also.
Yes, sir, with the centripetal filling.
Hmm. So it is there, peripheral heterogeneous enhancement noted, persistent in delayed phase. Hmm?
Yes. Might be a hemangioma.
Because another lesion also enhancing noted in. Huh?
On MRI, sir, it is demonstrating heterogeneous enhancement, sir, in segment 7.
Yeah.
So do you want more investigations or you're going to offer a plan of management?
Sir, as the AFP is low, sir, and 2 cross 1 centimeter lesion in segment 7. That is also showing heterogeneous enhancement. We can do a biopsy, sir, for that lesion.
You can do or I will do.
Mhm. Can you proceed without biopsy in such situation, Abhijit?
Sir, if the segment 7 lesion is
That
multifocal,
is what we are talking about, no? So is a biopsy mandatory or not?
more than one lesion, sir, on
That is what
MRI.
I'm asking. You will do it or not do it, or you will think.
Do it.
Yeah, I think, Dr. Madhu, what do you think? I think biopsy should be done in the diagnosis is in doubt. There's the possibility of multifocality. Other lesion is characteristic is not very clear.
Yeah. Because
Depends on what you're going to offer him, isn't it?
So yeah, what was the question was, no, you want to take a biopsy. I agree with that. I will take biopsy from segment 7 lesion instead of the segment 2, 3 lesion. Yeah.
So it's not, if the biopsy doesn't show tumor, what is your diagnosis?
Biopsy,
Segment 7 lesion is innocent.
yes.
Segment 5 lesion is too small to characterize. The segment 6 lesion is a cyst.
Vijay, can you go to that biopsy report slide?
they have done segment 7.
Yeah. So anything to suggest from this picture?
It is pointing out to microvesicular cholestasis, sir. So
Yeah, means do you want to do you trust this biopsy report? Means the report is not showing me everything. Means it is kind of, I thought it is some sort of liver fibrosis or liver nodularity, so some sort of aneurysm. To comment on cirrhosis of liver, maybe there is no such thing mentioned in this report, and only some steatosis is noted. So if the biopsy like this is negative, what will you do next?
if the biopsy is negative, sir.
Like this is a negative report, right?
Yes, sir. Negative for
What will you do
malignant.
next?
Then we can plan for surgery. What we can do is we can put a diagnostic laparoscopy, sir. and
No,
intra.
you can no. What you will do is important. Can is a very broad term. You anyway, before planning any major surgical resection, you are going to do a diagnostic laparoscopy. So with this kind of first biopsy, which is inconclusive, do you want to repeat a biopsy? Do you want to review the slides with your some serious senior pathologist or something like that?
Uh, if the pathology report is looking reliable, sir, then we can plan a diagnostic lab. We'll plan a diagnostic laparoscopy and intraoperatively we can send
So
a.
what is my opinion might differ. It's better to differ here that if the radiological picture is very conclusive and biopsy is negative, I would repeat the biopsy again. If the radiological picture is not very conclusive and biopsy is also negative, in that situation, maybe there is a difference in opinion. Here, the segment 7 lesion is not very characteristic that I said that liver lesions do evolve. So we sometimes do not know. And any invasive test, things like staging laparoscopy or biopsy, I think doing a repeat biopsy before proceeding toward staging laparoscopy and biopsy will not be unwise.
No, see, why the institution have done a segment 7 only biopsy, why not main lesion? There is some plan of further treatment, right? So if suppose segment 7 comes as a malignancy, what is the treatment option? If the segment 7 is benign, what is the treatment option for HCC? You know now, two types of treatment option for HCC.
Segment, if segment 7 is involved, sir,
So,
is malignant, then it's a multifocal HCC. So
hmm.
in that case, surgery is not indicated, sir.
HCC, what is the role of liver transplantation?
It's a three Milan criteria we have to follow, sir, in which if there is single lesion, this less than 5 centimeters, less than equal to 5, or 3 lesions each less than 3 centimeters, then that patient is a candidate for transplantation, sir.
So what he has mentioned 4.5 centimeters.
6.5. Size is
What is
6.5.
UCSF criteria then?
UCSF criteria, sir, if one lesion less than equal to 6.5 centimeters, and 3 lesions in which largest is less than equal to 4.5 centimeters, or the aggregate of those lesion is around 8 centimeters.
Now
Less
it
than 8 centimeters.
is fitting.
Yes, sir. This is fitting in UCSF criteria.
And then why you are saying no surgical role?
Then transplant is an option for him.
Yeah, the rationale of doing a excluding synchronous lesions as a malignancy or not. If that is negative, what is preventing you for resection, left hepatectomy? They haven't done a biopsy of main tumor. Do you know why?
Main tumor is a characteristic lesion in CT.
It's not at all classical.
It is showing more of malignant nature, sir, atypical HCC. Or can be
atypical. It's not showing a classical pattern of brightly enhancing an arterial phase. Washing and delayed phase is a classical of HCC. It's not filling like that.
yes.
Even
More like
MR also showing some hypodensities, hypointensive areas in the central. So it is also not showing classical, but it is a classical resectable. So tumor seedling you can avoid. That is the rationale of the done a segment 7 lesion, because if that is metastatic, your plan will change. If that is negative, so still what is preventing for resection?
You understand what is been told to you?
yes, sir.
Yeah. So say agree that the biopsy is negative in segment 7. Biopsy is negative. What is the treatment now?
Now, sir, we can go with a formal hepatectomy, sir, left hepatectomy, if that biopsy is negative.
Yeah. How will you plan formal left hepatectomy in this patient?
First, I would like to see about the functional liver remnants. The patient is child A, so he can undergo a resection procedure, sir. But given that the functional liver remnant is uh, greater
How much
than,
liver remnant you want?
sir, in the this is a cirrhotic liver, sir, so it should be greater than 50%, sir.
Yeah. What if where it said is above 40% is a you can proceed.
Yeah.
Nasal appendectomy, left appendectomy. Huh? In cirrhotic, normal liver 20%
20.
above.
Sir.
And fibrotic or steatotic or post chemo 35.
30.
Huh? Above you can proceed. So definitely it is left lobe and right lobe seems to be okay. If you still want, you can do volumetric analysis.
Any other tests you'll do before you do hepatectomy?
Yes, sir, that is important.
Exclude portal hypertension.
Yeah, that's important.
We can plan for hepatic free venous and hepatic wedge pressure because no collaterals are seen, sir, in the gastric and periesophageal region, and the
Very
portal vein is also looking normal on the CT. So nothing to suggest portal hypertension, sir. But to be sure, we can measure the hepatic wedge pressure, sir.
HVPG.
Yes.
Gastroscopy.
Yeah.
Yes, sir. We can rule out varices, sir, that would point out to portal hypertension.
Okay.
You know what,
gastroscopy
Abhijit?
is normal.
Presence of varices in upper GI endoscopy suggests clinically significant portal hypertension, right? And any surgical intervention, it helps in prognosticating the outcome of surgery. So if you are suspecting CLD in any patient and you're planning surgery, upper GI endoscopy is advisable just to comment on the significant portal hypertension. Or to find out if there are significant varices, you need to take care of that because post-surgery, these patients may bleed torrentially. And since this patient is possibly child, say, and liver volume looks all right, so Dr. Sitaram possibly wanted to ask any other thing that you want to do before doing major hepatic resection in HCC patient with CLD or cirrhosis to know the liver function is, remnant liver function is good or liver parenchyma is good. Any other test you want to do?
No, I want him to have a very clear idea about what he is going to offer the patient because this is a very common debate, isn't it? Hepatocellular carcinoma, whether you offer transplant or whether you offer liver resection. So you must have a very clear idea. There are very few debates which you will have to be thorough about in GI surgery, and this is one of them. So you should be very clear in your mind what you're going to offer the patient. Is he a transplant candidate or is he a candidate for resection? What are you going to offer? That you must be clear about. You have not done that in your presentation.
Sir, as the patient is having a single lesion that is resectable and the other lesions are negative for malignancy, sir. So this can with adequate functional liver remnant, performance status 0, and child's A, which can go which can undergo resection. So this candidate is a potential for resections.
No, in this case, what you will assess for remnant liver status? It's not showing gross cirrhotic, right? Not ascites, but still can possible. Chronic fibrotic changes. And the SGOT, SGPT elevated, you haven't tried for viral load status. Huh? Remnant liver, whether it is fibrotic or not. Because your clinical history only aiding is hepatitis B positive, long standing. I would like to do liver elastography or fibroscan of remnant liver, right? I would like to do always HBV with a LFT showing OTPT elevation. I always wants to do HBV viral load. If there is very high viral load, contemplating a major hepatectomy is dangerous. Patient may land in a liver failure, decompensation.
Is there any role of ICG retention, Abhijit, in this situation?
Yes, sir. ICG retention shows the metabolic ability of the liver, sir. So at
So
the
in
end
a
of
patient like this, where you are planning major hepatic dissection, do you
yes,
think,
sir, yes, sir. At the end of 15 minutes, if less than 10%
would you
ICG,
do it or you do not do it in your case? If you are planning for, since you said it is a candidate for resection,
yes, sir.
volume looks also all right.
Yes.
Would you do it or would you
Yes,
not
sir.
do it?
In this patient, as this patient is a case of chronic hepatitis B, with and there are other lesions also, sir, in the liver, however small, and high chance of fibrosis is there in the liver, and a ICG study to study the FLR is indicated.
Dr. Madhu?
So any other
Cross
investigation?
time,
Yeah, sorry, sir.
cross time. So,
Yeah.
shall we invite Dr. Shastri, Dr. Kapoor, Dr. Jaswant for their comments and wind up, I think.
Good morning, Dr. Sitaram. Good morning. VK Kapoor here.
Good morning, sir.
Yeah. So a few points for the students. You will frequently get such patients who have just upper abdominal pain with significant anorexia and weight loss. In such cases, I don't think at the end of the history, you should venture into making a diagnosis. You should interpret the case. Especially if it is a middle-aged or elderly patient, you should say, since there is significant anorexia and weight loss, I would seriously like to consider the possibility of a malignancy. And the possible organs in order of sequence, statistically more common, are stomach, liver, and pancreas. There may be minor hints. For example, if there is epigastric fullness, postprandial fullness, dyspepsia, then you can say stomach. Like in this case, if the patient is a known HPV or HCV patient, you can say liver. And if the patient has recently reported diabetes or worsening of diabetes, you could say pancreas, body, and tail. So that is how I would expect you to analyze the history. It's not necessary that in every case at the end of the history, you make a diagnosis. You should always list the possibilities. Second is a semantic point. Clinically, what we feel is a lump, not a space-occupying lesion. Space-occupying lesion is a radiological term, which is seen on ultrasound, CT, or MRI. Every MCH student should be able to read and explain CT anatomy of the liver, which is mainly decided by portal vein bifurcation, which divides the liver into cranial segments and caudal segments, and then the right hepatic vein, the middle hepatic vein, and left hepatic vein, which divide one sector from the other. So that you should be able to say clearly. A frequent mistake which students make, and this I have said so many times earlier, when a question is asked, you don't answer the question. You go around explaining it. So 3 questions which were asked to you, what is your diagnosis? You started summarizing the findings again. When Dr. Sitaram asked, what is your plan? You started giving justification. And lastly, when ICG was asked again, you started explaining what is ICG. If it is asked, what is your diagnosis? Say the diagnosis first, and then give the explanation. If you are asked, what is your plan of management? Say, I would treat this patient surgically, resection, transplant, embolization, chemotherapy, or whatever your plan is. And similarly, ICG. The other frequent mistake which students make is that you don't use the term in full. You just use a part or abbreviation, and then your answer fades away. That is not correct. When you were asked what is BCLC, you said Barcelona Clinic. You should have said complete answer, Barcelona Clinic for liver cancer. Similarly, you said hepatic pressure gradient. It is hepatic venous pressure gradient. At this level, since you are going to be super specialist, you have to be very clear, very specific, complete. Avoid using terms definitely and surely and certainly. There's nothing like definite in medicine. So don't use those terms, because some of the strict and finicky examiners may catch you on those terms. Again, if you are dealing with the possible diagnosis of malignancy, I think it must be a routine, both in the exam and in the clinical practice, to do just an ultrasound and a chest X-ray first, and then proceed with more expensive, invasive, or radiation-based investigation. So all patients with malignancy, you must have an ultrasound abdomen and a chest X-ray. I don't know whether I missed or not when you were reading the images, whether you talked of macrovascular invasion, involvement of the portal vein and the hepatic veins, because that is an important factor, as was highlighted by, I think, Dr. Azhar. Yeah, so one more point which I think I've forgotten. So students, please send me a mail, vkkapoor.india@gmail.com, write liver in the subject of the mail. I'll send you the chapter on liver from my operative surgery textbook. Thank you. Thank you very much.
Dr. Shastri.
Yeah, Abhijit, I think your performance is quite measured, although you got a little nervous in the later part. In any atypical imaging of a liver lesion, say which definitely this is, always opt for watching the images on console and discussing with the radiologist before you decide on a definitive management. Like you're jumping onto a liver resection before defining what this is. And in the evaluation of a liver lesion in patients at risk for HCC, you must always bring in LIRADs. This is definitely not LIRAD 5, nor 1 or 2. It's either LR4 or LRM, in which case, definitely it requires an alternative imaging, as you agreed, and a biopsy of the lesion. And sometimes, if it is single, a presumptive treatment without conclusive diagnosis. But then here you have multiple lesions. So you have to bring in more discussion points before you decide on a definitive management. I think these are the principles you must show. What you ultimately do, whether you do a transplant, just watch, do a biopsy of the prominent lesion. These are debatable points, which you must be ready with the debating points, but the principles cannot be ignored. These are the comments I thought I should make.
Dr. Jaswant.
Yes, sir. Morning. In the differential diagnosis, never forget the lymph nodes. In lymphomas non-Hodgkin lymphomas can present. In the same way, abdominal tuberculosis nodes that can cause also weight loss and pain abdomen, all things. So don't forget lymph nodes. And coming to the imaging, there's significant left lobe hypertrophy was there. Whether you observed or not, it is a lately hanging tumors. In any hanging tumors, usually the imaging may not be that typical. Usually hanging tumors will have atypical presentation. That's also. And it's a segment 2-3 tumor. No need for any left hepatectomy. Left lateral section is enough. Hepatectomy is enough. So it is operable tumor actually. We exclude other things. Thank you.
Pradeep.
Yeah, I think Abhijit, overall it's okay, but I think you should be more confident. See, liver SOL is a standard template, right? I think you should not forget it. What I found surprising is you started talking about tumor markers. You did not even ask for an ultrasound first. Without asking an ultrasound, why are you have already, it looks to me that you have decided that it is HCC. See, when Dr. Sitaram asked for an ultrasound, then you started telling about ultrasound. It is the first investigation, part of the extension of the clinical examination itself, as Dr. Kapoor also is highlighting that ultrasound is a part of the procedure, because that's from there you take off, because by that time the clinical history, clinical examination is over, and ultrasound will guide you where your tests are going to be. Suppose if it were to see a stomach, if the liver is normal on the ultrasound and there's a mass in the stomach, so all this discussion won't happen. Then you straight away next investigation would go to the endoscopy. So the ultrasound forms a very important part of your clinical evaluation. I mean, immediately after that investigation. Don't forget this. So otherwise, I think you should be more confident in telling your body language appears. Sometimes you are not, till the examiner asks you, then you agree with that. So at this level of examination at a super specialty, you should be more confident. So I think to went in detail left. I think Chidanand, yes, can you show that this thing?
Yes, sir.
Patient.
So you can tell what's done.
Yes, sir. Left epitomy was done, sir.
Uh,
And the final biopsy showed the HCC, mild to moderately differentiated. Margins were clear. And the remnant liver had changes of cirrhosis, sir. 20% cirrhosis changes, sir.
So in a cirrhotic patient, you should be very worried about looking for a portal hypertension. That's what Professor Madhu also was highlighting. So you should definitely look for a hepatic venous wedge pressure before you take a decision on the major resections in a cirrhotic liver. Any other last comments, Madhu and Sitaram? Then we can wind up otherwise.
Yeah, it's fine, sir.
I think that's fine.
Yeah.
It's fine.
Okay. Thank you, Abhijit. Thank you, Professor Sitaram. Thank you, Madhusudhan, and thank you all other faculty members as well.
Thank you, sir. Good.
Thank you.
Thank you.